Hello. Today I'm going to talk to you about Foley care, peritoneal hygiene, and continuous bladder irrigation. When dealing with Foleys, the main thing to focus on is preventing CAUTIs. So CAUTIs are our catheter-associated urinary tract infections, and our very best tool for CAUTI prevention is the Promise package. So when you're placing a Foley, you should always make sure there is an order. Even if the Foley was taken out for a voiding trial and it's now being reinserted due to a failed voiding trial, there needs to be a new order. Each shift in EPIC, you're going to need to complete required documentation, especially paying attention to peritoneal hygiene. The CHG bath will need to be documented once per day, and ideally this should be done by 11 a.m. At the very latest, these patients need to have a CHG bath by 5 p.m. If the patient is refusing, this should be documented. Page 19 of the Promise package describes the escalation process and recommended scripts on handling this situation. To stay in compliance, we must complete the Clean For You bundle and peritoneal hygiene by 11:59, even if the Foley was placed in the OR or the ED and then comes to you. Okay. Please refer to Piedmont University Lippincott modules for specifics of peritoneal care of the male and female patient in regards to indwelling Foley catheters. Continuous bladder irrigation, sometimes it's called a Murphy drip, is what you see here. This is used to help prevent urinary tract obstruction post-prostate or bladder surgery, and it does this by flushing out small blood clots. It is sometimes also used to treat irritated, inflamed, or infected bladder linings. So to do this, it requires the placement of a triple lumen indwelling catheter, as you can see here. One lumen controls the balloon inflation. A second lumen enables the irrigant to inflow, the fluids to go in. And a third lumen allows the outflow. The continuous flow of the irrigation solution through the bladder creates a mild tamponade effect, and this is going to help prevent venous hemorrhage. So ideally, you're going to see a large 22 French catheter being placed. When you receive these patients, you'll see Y-shaped tubing set up to a single chamber. So it'll look like this here. The irrigation bags are 3,000 ml, and these will come to you from pharmacy. You should always have several available. Keep at least 2 in the patient's room and ideally 4 in the medication room at a time. You will need a cart to go get these from pharmacy. They're very heavy. When you give these, do scan the patient's armband before you hang them. They do need to be documented as a medication administration. And you will always hang 2 at a time. However, only 1 clamp will be open at a time. So you have 2 clamps here. Only one of them will be unclamped at a time. The other one will remain clamped. Make sure before you begin the irrigation that the catheter is secured to the patient's leg. A lot of times a leg strap can be used for this due to how heavy and how thick the catheter is. And you will also need a 4-liter drainage bag for this, not the standard 2-liter drainage bag. Otherwise, you'll be emptying it very frequently. You will need to record intake and output very carefully for these. So sometimes it's helpful to have a paper at the bedside so that everyone can keep track of this. Okay. The goal is to titrate it to achieve a clear pink colored output. So that is the CBI setup. The biggest hazard with CBI is clots that clog and constrict the catheter. One possible reason that this can happen is that your irrigation bags, the bags hanging, run dry. This shouldn't be an issue if the second bag is continuously replaced as soon as it finishes and you're able to open the second bag that's hanging at that time. There is no harm in asking the patient or their family to alert us as soon as this happens. This will happen fast. These bags run dry quickly, so have them involved in their care to let you know when that bag is running low. The second thing that happens is when the drip chamber is full, this chamber here, when that gets full, you cannot tell if the fluid is flowing or not. So we'll show you what a full chamber looks like. If you see this, you cannot tell if the fluid is flowing. So in that case, what you need to do is put fluid back into the bag. So you'll have to take down one of your bags, just like an IV bag, and put some of the fluid, squeeze the chamber to allow the fluid back into the bag, as such. Now you'll be able to tell if your fluid is running or not. The third issue that can happen is when your urine bag is full. When this happens, the urine is going to back up into the bladder and it's going to be very painful and dangerous for the patient. So keep that bag emptied often. The fourth issue you'll see is dark maroon color in the collection bag with clots. This is especially a problem if the urine output is small and you see the patient is getting a lot of irrigation intake, meaning these bags are running quickly, but you're still seeing maroon and clotty output. In that case, you're going to need to irrigate the bladder and irrigate the catheter. Okay. So we're going to show you how to do that. We're going to look at that. Make note which part of the catheter is the output collection, goes to the output collection bag. So trace your lines back. Once you get to the collection bag line, that is the line that you're going to use to irrigate the catheter. Okay, the one that goes to the collection bag. So to do this, and one way you'll know you need to do this also is if the patient is experiencing pain and feels like their bladder is full. So clean your hands, don your gloves. You're going to immediately turn off the irrigation. To turn off the irrigation, you simply clamp the clamps here. Make sure they're both secured, and then clamp your roller clamp. You have a roller clamp here. This roller clamp is what you use to control the rate of flow. So close that off. Okay. Then you're going to use a rectangle irrigation tray, the piston syringe tray, to irrigate, and you're going to grab a 500 bottle of fluid or sterile water, pour it into your piston syringe there, and use that. Pull up the saline. Start with a small amount. If the bladder's already full, there's not a ton of room to add more fluid. So start with a small amount of fluid, maybe 5 mLs. So you do have to break the red seal on the outflow line here. Break the red seal, disconnect your catheter, insert your piston syringe, and flush the bladder. When you pull back, you'll start seeing the red clotty urine come out. You should discard this. Do not put it back into the bladder. Discard that over into your container. The goal of this is to remove as many clots and fluid as you can, and then repeat the procedure until the patient gets relief and the urine flows freely. So once you've achieved that, you hook your bag back up to the line. You can come back over to your roller clamp and start the flow of your fluid again. See how When you unclamp, it starts to flow. And then as you control your roller clamp here, the rate slows down. Okay. The rate that you're going to use for flushing your patient is the rate that you need to achieve the goal, which is the clear to pink urine. As the urine starts to clear, you can decrease your flow rate. So when you irrigate, just remember, most of the urologists live far away. So if you've tried all of the above and you're still having a problem, so you're going to need to call them. Be as specific as you can. Describe what the pain is, what the issue is, and describe what the urine is like. We expect all CBIs to be bloody. That is what's going to happen with this. So the correct descriptions to give the urologist would be the color of the urine, such as cherry red, rose, port wine, maroon, light pink, or yellow. And it can also be helpful to save a urine sample for them to see when they do arrive. But again, it is better to reach out to them, describe the issue, and let them give you guidance than to have the patient hemorrhage or be in an excruciating pain. All right, thank you.